Need time for introduction right now because you all have met Dr. Biju yesterday. So we'll move on to the difficult communication part, which I think you already there were discussions in the group and many other questions. So over to you, sir. We don't need any introduction today.
Thank God for that. So we can straight away get on to brass tacks. I will start sharing the PPT. So I hope you can see the slide.
Yes, sir. It is visible.
All right. So welcome everybody once again to the communication skills program. Today we are going to do part two, and we'll straight away get onto it because there's a lot of ground to cover. And so we are going to do some advanced communication procedures. The reason why I call it procedures is because just like any procedure, there is an indication, there is a standard operating procedure, and an expected outcome out of the procedures that we uh, do as far as communication or counseling is concerned. So today we are going to talk about three procedures. One is communicating bad news, and then there is collusion management, and third is anger management. So we'll start off with communicating bad news. We'll talk about some of the models uh, that are practiced and the rationale why we need to communicate bad news at all. From there we will take a deviation to collusion management, and we'll talk a little bit about it, and then we'll come back again back to communicating bad news. Here we will talk about how to go about doing it, and last we will talk a little bit about how to deal with anger in our day-to-day clinical practice. So essentially, breaking bad news is nothing but truth telling, and as every one of you can imagine, it's not easy to tell the truth, especially if the truth is something unpleasant to hear. All over the world, there are different models of communicating bad news. In our part of the world, most of the developing, underdeveloped world, or most of the Orient culture, if I may put it like that, the Asian culture, we practice non-disclosure model. And what does that mean? The patient and family comes together into our room, and we have something unpleasant to tell, and we tell the patient, please go out. And then we talk to the family. The patient standing outside, clearly knows that we are talking about him or her, and the person clearly knows that we are purposefully not telling the truth to him or her. But then that is how we deal with communicating bad news. We do not tell it to the patient, we tell it to the family. There are other ways of conveying this to the family without telling the patient. So we may surreptitiously ask the family member to come out into the corridor, and there we disclose the bad news, not in the room while the patient is there. So there are many ways of doing it, and we have a lot of justifications for not telling the patient because we are essentially kind-hearted people. We don't want to burden the patient with bad news, etc., etc. In some other uh, um, part of the world, the model is different. Now, the problem with non-disclosure model, that is, you not telling the patient, is what if the patient wants to know, right? And the principles of autonomy says the patient has the right to know, and the patient may want to know for various personal reasons. They may want to plan something, for example, or the patient just wants to know. So when we practice non-disclosure model, this can get into conflict with a patient who wants to know because the patient has the right to know. And as I mentioned earlier, in some parts of the world, they practice full disclosure model. That is, the patient is told everything, the truth, the full truth, and nothing but the truth. And in those kind of cultures, you need to take the permission of the patient to talk to the family. You cannot talk to the family without the permission of the patient. So many of these uh, places, most of these Western developed countries, uh, some or the other form of full disclosure model gets practiced. And there, the reason they have to practice is, one, they believe that the patient has the right to know. Secondly, sometimes it may be legally binding on them to practice this way, etc., etc. Now, what about a patient in those kind of environment who does not want to know? So here also a conflict happens, because autonomy means the patient also has the right not to know. The patient may not want to know for various reasons, just don't want to be burdened with such a knowledge. So the prevailing two models in the world, that is the full disclosure model and the partial disclosure model, both has its set of problems, because it can get into conflict with the patient who wants to know, or in conflict with a patient who does not want to know. Basically, the problem is we don't know what is it that the patient, basically we don't know the person in front of us, whether the person wants to know or not. So that is something that we need to consider. And therefore, we talk about an individualized disclosure model. Now, basically, what that means, it means you first figure out whether the person sitting in front of you wants to know or not. And then, if the person wants to know, only then you convey. If the person does not want to know, you do not convey the truth. The second part of that is, if you have a patient who wants to know, then we have to figure out how much the person wants to know. Does the person want to know 50%, 63.8%, 79.2%, or 100%? We have to figure that out. So there are two components to individualized disclosure model. We want to find out whether the patient wants to know or not, and if yes, then how much. So that is the challenge in this individualized disclosure model, and that's precisely what we are going to learn today. But before we get there, some more very, very fundamental things. Why should we communicate bad news at all? What's there? What's the benefit out of it? Now, if somebody wants to know, letting that person know has some benefits. I put it into three primary reasons. Closure of life's business. For example, it will give a person a chance to finish off the things that he or she wants to do, whether it is dealing with finance, whether it's the password in the bank, telling it to the spouse, or at least mentioning what he or she wish should be done for the children. uh, it also gets them an opportunity to finish off, or do things that they have always wanted to do, for example a bucket list, but never got around to doing it. It's also an opportunity to mend broken relationships and to strengthen good relationships. It's also an opportunity to ask for forgiveness and to give forgiveness. So there are a lot of things that one can think of and do while one has reasonable physical and mental health to do it. So knowing a bad news has a benefit of this part of letting a person or giving a person a chance to finish whatever they needed to finish. Another area is that when the person does not know what is going on and the patient's expectation is way above reality, then whatever the best possible excellent care you give, it will not match the patient's expectation. And thereafter, what happens is, after some time, the patient feels disillusioned, dissatisfied, and eventually will decide that, good people, good hospital, but they are not, giving me what I'm looking for. And if the patient says, let's go to some other place, let's go to some another hospital, the family, because the family has not told the patient what the truth is, the family has to play along. They also, then they take the patient to another hospital. And when the patient goes to the new hospital, the patient has high hopes that now here things will be better. But after some time, the same disillusionment happen, disappointment happens, loss of hope happens, and then the patient will ask to be taken to some other place. So this goes on and on. So from one doctor to the other doctor, from one hospital to the other hospital. So patient will end up blaming the hospital, the doctors, the caregivers, the medical system, and eventually will start blaming the family members, and even sometimes make allegation that you don't want me to get better, you're after my money and things like that. So a lot of hurtful things can be said because the patient does not understand what is going on. It's a miserable situation for the family as well, because the patient is dissatisfied. They can't tell the patient, oh, just stay back here and take whatever treatment this doctor is giving. So they are forced to take this patient to other places, and because of that they can't earn, because somebody has to be with the patient. Sometimes more than one person has to be with the patient, and because they can't earn, the income kind of dries up, and because they are going from place to place, the expenditure just shoots up, and they end up having to sell off the cow, having to sell off the jewelry, having to sell off the utensils in the house. The children have to drop out of school. Eventually the house they have to sell off and move on to a smaller rented accommodation, and this happens over and over and over. A large chunk of our population is pushed into poverty because of futile medical expenses. And this is a tragedy that we need to prevent, both at the personal level, at the patient and families level, and at a macro level, in terms of poverty. I'm not saying all the poverty is because of that, but a fair bit of poverty. People get pushed into poverty because of unmanageable medical expenses. Another area is barriers in relationships. So the patient does not know what's going on, and the family members have to pretend as if everything is fine. And sometimes they get overwhelmed because in front of the patient they cannot show their true emotions. So they get overwhelmed by doing this play acting as if everything is normal, and then they have to go to the furthest room in the house and break down and cry there, and then they have to wash their face and then again come back and play the same drama in front of the patient as if everything is okay. Or they go into the neighbor's house and cry there, or the friend's house, or they come into your office and cry there if the patient is not accompanying them, because they can't cry in front of the patient. And it's a very miserable way of going about it. And then the patient also understand, because the patient, like any human being, can read body language. The patient understand that they are hiding things from me. You know uh, they are hiding things from me, and they are not telling me the truth. The patient understands that something is terribly wrong. The patient's body is communicating with the patient. Patient's body is telling the patient that things are not fine, and every day things are going down the drain. The patient understands that, but just not doesn't have the clarity as to what exactly is going on. And this can cause a lot of frustration, anxiety, temper tantrums, behavioral issues, and this causes a lot of negative energy in the house. Sometimes the house implodes because of so much of negative energy and so much of pressure. And then the patient feels isolated. The patient feels nobody's on my side, nobody's opening up to me, nobody cares about me, nobody's on my side. I'm all alone, and all of them are together. So they discuss all the things. I can hear the whispers in the next room. I know they're talking about me, but nobody talks to me. So all of this, the patient feels isolated, families in a lot of distress, a lot of relationship damage happens during these situations. And in the end, finally the patient dies. And then the family members look at the photo of the patient with a garland and wish we had some more time. But what were you doing when the patient was still there? We were playing a drama. A lot of painful memories accompany this kind of situation. And only if this kind of if we had some way of guiding the patient and family towards being honest and transparent with each other. And that is what truth telling is all about. So if you feel that communicating bad news carries a negative connotation, change the heading and make it to, why truth telling is good. Yeah. So instead of communicating bad news, we are learning truth telling. So, these three major points: closure of life business, hospital hopping and doctor shopping, and barriers in relationships. These are the reasons why we would advocate that it's important to tell the truth to the patient, and thereby creating transparency and honest sharing of information between the patient and family, and between the patient family and us, the medical professionals. Our lives will also be less complicated if the truth is out there. So having said all of that, we know it is not easy. Many a times the family members will come and tell us, doctor, please don't tell to the patient. They will literally come and beg to us. Sometimes they will come before they bring the patient into the room, and then they'll come and plead to us, doctor, please don't tell the patient. So many of you would have been very familiar with this in your professional life. And this is what we call as collusion, basically a conspiracy of silence. The patient party, the family members, tries to influence us to enter into a conspiracy of silence, thereby keeping the patient out of the information loop. Basically, the family wants that we, medical professional, doctors, nurses, everybody, they share the information, but keep the patient out of it. This is basically what collusion means. And why do they do it? Because they are trying to protect their loved one. So there is no malintent by and large. It's because they've loved this person who is sick with a terrible illness. And they believe that if the person came to know the truth, it will harm. And for them, their belief is real. And if we try to challenge that belief, we'll only end up making them more anxious, because they are already anxious and scared when they are coming to meet us for the first time, because they don't know what kind of a doctor this person is. That's why they come and plead, because they are scared of us. At the same time, they need our services. Look at their dilemma. And if we say, no, 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 we should tell the patient, then their worst fears are coming true. So do not challenge their belief. If they say that, if the person gets to know, he will immediately die, that is their belief. And if you say, ha, don't be stupid, that never happens. But you can't reason with belief supercharged with emotions. And if you insist, then they will just simply take the patient away to some other place, and you lose the chance to do whatever good you could have done for the patient. So do not challenge their belief. If from your point of view it is irrational, it is illogical, it is stupid, but for them it is real. So what to do? Agree to collude. Just say, okay, fine, no problem, I will not tell him. That's about it. So the reason why you are uh, saying this is because you are not only required to relieve the suffering of the patient, you're also required to palliate the suffering of the family. Right now, the family is suffering with severe fear and anxiety. And when you say, fine, no problem, I will not tell, you are trying to palliate the family's anxiety. And that is very important, because you need to bring the anxiety and the fear of the family down. And in any case, you cannot tell the truth to the patient without the green signal from the family. You will get into a lot of trouble, especially in our culture, where the patient's autonomy is always below the family's right over the patient. In our culture, it is the family which brings the patient to us. It is never a patient alone walking into our office, right? So agree to collude and earn the family's trust. How do you earn the family's trust? Listen to the family. Yesterday, we talked about active listening skills. Use all of those skills and build up a relationship. Another way to fast track getting the family's trust is to make the patient comfortable as soon as possible. That is where your symptom management, symptom palliation skills will come in. You relieve the patient's pain, the patient starts smiling, the family will start trusting you. So relieve the patient's suffering. That is a great way of earning the family's trust, apart from practicing all the active listening skills with the family. And once the patient's family starts trusting you, then they will start listening to you. They will not listen to you till they trust you. And once they trust you and they start listening to you, that is a good time to start reorienting the family. Talk about why it is important to tell the truth. What are the benefits of telling the truth? Now, this is a skill which unfortunately I can't teach you on this session right now because it is a very, very difficult skill. The failure rates are high in the beginning, conversion rates will be low in the beginning, and but as we practice and get better, the conversion rates improve. But this requires a fair bit of demonstration and mentoring. But basically, the SOP is like this: agree to collude, earn the trust, and once the trust has been earned, reorient the family. And once you have reoriented the family, sometimes the family member may tell me, Doctor, I can't tell this to him. Why don't you tell? So then you offer your expertise. Okay, fine, I will talk. In addition, I also tell the family members, see, I will explore things with the patient, but if the patient does not seem interested in knowing, I will not push it. I will not force the information. So even though I agree to tell the truth to the patient, I make it clear to the family that I will not shove the truth down the patient's throat. I will leave it to the patient to decide whether the patient wants to know or not. If you find a family which is a tough nut to crack and you feel that, hey, I'm failing, I'm not able to convince them, please don't make this as your agenda that you have to convert the family. No, because if you push beyond a point, they will start pushing you back. And that is where the relationship starts breaking down. And we don't want this, especially when you're dealing with a terminally ill patient. You want the family to be on your side. So it's very important to try and be prepared for failures. There is no shame in failing. The only shame perhaps is not in not trying. So try pollution management with every family, but be prepared for failures. And over a period of time, your conversions will improve, but it will never be 100%. The best communication, the best counselors, they often have failures. So rest assured, failures will be there. But with practice, things will improve. Coming back to communicating bad news, the standard operating procedure world over is the spikes protocol. Basically it's an acronym which stands for setting up the interview, assessing the patient's perception. Yesterday we talked about the patient's insight. What do they know? What do they understand? That is perception. And then obtaining the patient's invitation. That is, we will tell the patient only if the patient wants us to tell. So that is what invitation is all about. And if the patient invites us to share the knowledge, then you share the knowledge, you give the information, and you do it honestly. And then what is to be expected? Emotions. And then what we are supposed to do? Deal with emotions. And we'll talk about that. Because until and unless you deal with emotions, then you cannot talk about what can be done, what cannot be done, the strategy to be employed, etc., etc. Because when emotions are high, then the logical part of the brain stops working. So we have to deal with emotions, and subsequently, then we can talk about how we can go about managing it. So this is basically the protocol. And please remember that today we are just going to talk about it uh, in a way that just gives you an insight of how we can go about it. But remember, depending on the situation that you find yourself in, you may have to change the nature and character of how you go about it. But we are just talking about the signposts that are important And the standard operating procedure, this is how, just like you learn history taking in your MBBS time, and then you learn that skill, and then use it according to your requirement as a practitioner of your area of science. So it will be different from how you learned it. So here we are going to learn how to communicate bad news, but that is not the only way you can do it. You can modify this this standard operating procedure. So here is a story of Mr. Bharat, who is a 60-year-old gentleman. He had an abdominal discomfort and weight loss of about 2 months duration. So he went to his local GP, and the local GP gave him some medication for 1 week and did not work out. So he was referred to gastro doctor at the city hospital, where a CT abdomen has showed a mass lesion of the stomach, and endoscopic biopsy showed a histopathology of a CS stomach. And he was advised a surgery and exploratory lab was done, which showed multiple peritoneal metastasis, and therefore it was just closed without any particular disease intervention possible. And subsequently, this patient was referred to you for symptomatic or supportive care. This is the usual words that the non-palliative doctors use when they refer to the palliative care. The people are a little reluctant to use the word palliative care. So they use words to the effect of symptomatic care or best supportive care and things like that. So you have this patient sitting in front of you. Now, what do you do? So this is the medical story, and this is the easiest part. So let us hear from the patient. So we ask the patient, yeah, tell me, what brings you here? So the patient's story goes like this. I have had gas since about 2 months, and I went to the nearby doctor. He gave me some gas tablets. There was no relief. Then he took an X-ray of my stomach, and after that, he gave me a letter to see the gastro doctor in the city hospital. The gastro doctor did a scan and a tube test, and then he told the surgery was needed. But I did not have any money. So I told him that I'll go back to my village and get money, and then I'll come back. So then I went there and I had some money saved. Then I had to borrow some and things like that. I sold my cow as well. And then they gave me a date for the surgery, and then the surgery was done. After surgery, they gave me this letter to come and see you. So this is what the patient tells you when you take the history. Now, the thing is, there are a lot of information that is not there, which we need to dig out. And that is what we call about trying to understand what does the patient know, the patient's insight, the patient's perception. And I'll give you an example of that. So the same story with a little bit more of digging. So tell me what brings you here. I had gas since about 2 months. So I went to the nearby doctor. He gave me some gas tablet, but there was no relief. And then he took an X-ray of my stomach, and then and then he sent me to the get. One second, one second. What was there in the X-ray? What did your doctor tell you? Uh, I don't know. I don't know what was there in the X-ray. So doctor gave me a letter to see the gastro doctor at the city hospital. Okay. Did the doctor tell you why he was referring you to the gastro doctor at the city hospital? I guess for better treatment. Okay, go on. So there the gastro doctor did a scan and a tube test and then asked me to do a surgery. Wait, you said gastro doctor did a scan test. So what was there in the scan? What was the result of the scan? I don't know. They said something in English. I could not understand what it was. And then what about the tube test? Oh, tube test was horrible. I felt like vomiting. Yeah, usually it is little uncomfortable. But what did they tell you after doing the tube test? They said I have to do the surgery. No, but what was there in the tube test? What was the result? I don't know the result. Uh, they said I had to do a surgery. Okay. Then what happened? I did not have any money, so I told them I'll get the money and come back. So I went back to my village, and then I had some money saved, and then I borrowed some money. I also sold my cow, and then I went back and I got a date and got the surgery done. And then they gave me a letter to see you. Just hang on. So what happened after the surgery? Uh, what did they tell you after the surgery? Well, after surgery, my gas problem is gone, but I'm feeling a little more and more tired each day. I'm not getting better. So what did they tell you? They told me to take this letter and come and meet you. Did they tell you why they were referring you to see me? They said for better treatment. So when you dig for more information, you will understand what does the patient understands, and you will know that there are some things that the patient may understand correctly. There are a lot of blank spots. The patient has no idea what is going on, and some places the patient has wrong ideas. So this is the sum total of the patient's insight. This we will get only if we dig for more information. What did they tell you? What was there in the result? What did they tell you? What what did you understand? So when you ask these kind of questions, you get to know what their insight is, what their perception is. So this is very important because now you within your mind, you know where are the blank spot, what does the patient know, what the patient doesn't know. And this is important when you are going to tell the truth, because you will be just filling in the blanks. For that, you need to know where the blank spots are. Before starting the procedure, do some pre-procedure preparation. Read upon the patient's medical condition if you are not fully familiar. Even if you are familiar, it's good to go through it. Communicating bad news, truth telling is an elective procedure, so try allocating a dedicated time for it. Set a conducive environment, preferably less noisy environment. Arrange enough chairs to sit. In my room, I always have some additional plastic chairs which I can stack up, so it does not take up much space, but when required, more and more people can be comfortably seated, apart from the standard patient and family, chairs. It's a good thing to have some drinking water and some paper tissues, because inadvertently there would be some crying. So, be it's good to be prepared. And then practice active listening skills that we talked about yesterday. So first thing, if the patient by himself or herself says, doctor, what is my problem? Tell me what my problem is. Then you don't have to explore, because the patient himself or herself is already asking. So if not, because sometimes patients don't know whether they can ask, or sometimes patient that thought may not have crossed the patient. So it's important to, from our side, we make an effort to explore if the patient wants to know. Mr. Bharat, you told me you continue to feel tired. Do you wonder why? Do you want to know more about your disease? Yes, I do want to know more about my disease. So this would be a natural reaction to explore. Now, that does not mean we straight away tell this person, oh, you have cancer. No, you have to give a warning shot. Mr. Bharat, if it is something serious, would you still want to know? The warning shot is the point where the patient can be differentiated between those who really want to know and those who really don't want to know. That is the differentiating point. Remember, in individualized disclosure model, the first criteria was we have to figure out whether the person sitting in front of us wants to know or does not want to know. The warning shot does that for us. So in the standard operating procedure of truth telling, giving a warning shot is very, very important. There are two components to it. We convey that there is something serious. And the second component is, do you still want to know? In Malayalam, I would say, കാര്യങ്ങള് serious ആണെങ്കിലും അറിയണമെന്നുണ്ടോ? In Hindi, I may say, अगर बात कुछ serious है, तो फिर भी क्या आप जानना चाहेंगे? In English, if it is something serious, would you still want to? Now, this, apart from the other, this differentiation part, it also changes the mood of the interview. From a normal interview, it becomes a serious interview. So now the person who wants to know will be fully focusing on whatever we have to say. So you have given a warning shot, and if this is the body language you are seeing, no eye contact, patient is not looking at you, then that means the person does not want to know. Or if the patient says, change, give some excuses, give me some medicine and I'll come back after 2 weeks, means the patient does not want to know. Or the patient, deflects to tell it to my children. The patient does not want to know. Or sometimes the patient may say, I don't want to know. Then, so either of these, the words or body language, whichever you are seeing, if it is something like that, do not proceed. Do not proceed with truth telling. Whereas if you have a patient like this, looks into your eyes and says, yes, I want to know, no confusion. Here is a person who wants to know. That is, after giving the warning shot, if the person looks into your eyes and says, yes, and even if the person is not making an elaborate speech, just yes, or just looks into your eyes and nods the head, that means yes. Remember, major part of communication is body language. Then you can proceed. So this is how you differentiate between a person who wants to know and who does not want to know. And once you have made that differentiation, then the person who wants to know, you tell a story of the patient to the patient from the beginning of the patient's problem. And while you're telling the story, you fill in the blanks and escalate the information as you go along. And while you're telling the story, somewhere if the patient's eye contact goes, then pause the story then and there, because the patient may have got a chunk of new information. The patient swallows it, is digesting that new information, may need some time to process it, and therefore the eye contact may go. Once the patient has understood the implication of the new information, the patient may again make eye contact. Then you can unpause yourself and start the story. Sometimes if the pause is getting very, very long and you are getting uncomfortable, you don't know what to do, then you can break the pause by asking a question. Do you want to know more? Should I proceed? What are you thinking? So something, a question like that will break the pause. And if even after that the patient does not make eye contact, then probably the patient had enough. So that's how you find out how much the patient wants to know. And if the patient is indicating by body language or verbally that the patient had enough, you stop the story there. Or you continue to give information till the story finishes. So stop wherever the patient wants you to stop, either at 58.9% or 62.3%, 78.4% or 100%, wherever the patient takes you. Basically, it's a patient-led session. We are only facilitators of information. So here is a role play for you of truth telling, telling a story. Mr. Bharat, you have been suffering from gas since about 2 months, right? And you went to your local doctor and he gave you some gas medicines. You told me you took it for about 1 week, but there was no relief. So you went back to him and he asked for an X-ray, right? The X-ray actually showed something like a shadow. And to know more about the shadow, he referred you to the city hospital. Oh, I didn't know that. In the city hospital, they did a scan, right? You told me about the scan. The scan showed something like a tumor. And to know what this tumor was, they did a tube test called endoscopy. Now, if you go back to this, you will see I am filling in the blanks and escalating the information. They saw something like a shadow, and in the next sentence, something like a shadow becomes shadow. Something like a shadow becomes shadow. It is no longer something like, it is shadow. And subsequently, shadow becomes something like a tumor. And in the next sentence, it becomes tumor. It is no longer something like a tumor. So that is how you're filling in the blanks and gradually escalating the information. So I have mentioned tumor, eye contact is there. So I proceed with the story. The tube test was done to see if your tumor was something like a cancer. Do you mean to say that I have cancer? Um, I'm sorry. Yes. Mr. Bharat, do you want to know more? They had operated and removed my cancer, didn't they, doctor? I'm sorry. When they opened up your tummy, they found that the cancer had spread all over. They could not remove it. They lied to me. So now the emotions are coming. And remember, emotion can come as tears or it can come as anger. They lied to me. Whatever it is, whether it is tears or it is an angry outburst, both are emotions. And for that, we have to wait for the emotion to flow out completely. Now, this is the most difficult part. What are you supposed to do as a doctor? We all our life, we have been trained to do something. But here, what you are required to do is don't do anything. Don't say anything. Don't do anything. Just be with the patient. Your being there is the important part. Your being there is the therapy. Because when people are emotional, they have to ventilate. They cannot ventilate on inanimate objects. They cannot ventilate on the wall. They cannot ventilate on the chair. They cannot ventilate on the table. They need a human being to ventilate. And there you are the human being to which your patient is going to ventilate. And you have to wait for this person to ventilate and finish ventilating. It is like doing an ascitic tapping. You tap and you allow the fluid to drain out. So you are the tapping tube through which the patient's emotional distress has to drain out. So don't do something, don't say something, just be with the patient. If at all appropriate, you can touch the patient for a moment and then take your hands off. Don't leave your hand there over the patient's body and forget about it. That's the big cruelty you can do to them. Don't pat. Don't say there, everything will be all right. Don't say things like that. Just quietly be with the patient. Difficult thing because nobody taught us how to do that, but that is what is required. And once all the emotion has been drained out, it doesn't take long, by the way. A minute or two is more than enough for the patient. But that minute or two seem like 1 or 2 years. It seems like it is stretching forever. And that is where the mentorship and the training comes in, where you sit there purposefully, fully there, not looking at the notes or playing with your mobile while this person is ventilating. No, fully 100% focused on the patient. And once that emotion has been drained, be prepared for questions. How much time do I have, doctor? Now, when people say something with emotion, do not assume they are saying for a particular reason. We don't know. Why this person said, how much time do I have, doctor? So do not assume, ask. That's the simplest thing that we can do, but most of us don't. We'll assume. So just ask, why do you say that? My daughter's marriage is fixed after 6 months. Should I prepone it? What should I do? So here is a person who asked, how much time do I have, doctor? Because this patient wants to plan. Another scenario, how much time do I have, doctor? Why do you ask that? Why did God do this to me? So here is a patient who does not have anything to plan. This person just needs to ventilate more. But the sentence was the same. How much time do I have, doctor? But the reason why two people asked that was for two different reasons. 10 people will say the same thing for 10 different reasons. So please understand, when somebody says, I'm so scared, I'm so worried, I'm so anxious, why did this happen to me? When people say things like that, don't assume they are saying this for so and so reason. Just ask. That's the simplest thing. Ask, and they will tell you why they said whatever they said. Do not assume. And once you have answered those questions, then once the emotions have come down, then you can share information on what can be done, what cannot be done, where they have to go, what needs to be done, how much it's likely to cost, how long it is likely to think, and etc., etc., etc. Yesterday I talked to you about what I usually end up having to say to patients who come to me when they are terminally ill. I tell them, see, your disease is no longer curable. So, but basically, I'll make sure that you are comfortable for as long as you need to be. So, when whatever you have to you say it with honesty, you say it with sensitivity, and never let the patient go without some realistic hope. That means never give false hope. All the things that we talked about yesterday. And that is where we finish the story by sending the patient home with realistic hope that even if the disease is incurable. Now, this telling the bad news, you can do for patient with a bad illness which is curable or incurable but chronic or terminally, doesn't matter. For that person, it is a bad news. The truth is a bad news. Nobody likes to get sick. If they get sick, at least they want to have a disease which is curable. If it is not curable, at least they don't want to die of it. They want to have it as a chronic disease. And if at all they have terminally ill, at least they don't want to suffer. And if suffering is also not possible, at least they don't want to be abandoned. So you make sure that at no point of time they feel helpless and hopeless. You always give them a feeling that I am there to make sure that you will be comfortable and I will never abandon you. I will never say, don't come to me again. Because in palliative care, we have this advantage of never having to say nothing more from my side. Because as I said yesterday, there can be limits to cure, there are no limits to care. Now, coming to anger, very often we have anger situations in our clinic. And please remember, I am not talking about law and order situation. If you have a mob of 50 people and trying to create havoc in your hospital or clinic, run for your life because you are not trained to wield a lathi or a gun. You are not a law and order expert. You are not a policeman. You are not a paramilitary. You are a doctor, right? So you can wield a stick, but you cannot wield a gun or a lathi. So if it is a law and order problem, you are not the right person to deal with it. So have some clarity on what you can deal with and what you cannot. Same goes for people under the influence of alcohol or other substance abused and are becoming very violent. They are not open to reason. That's a law and order problem. In that kind of situation, run for your life and live to do good things another day. So basically, what I'm talking about is every day you have a lot of people, patient families coming to your hospital, coming to see you on a daily basis. See, hospital is a place where people don't like coming. They have to come because they are ill, they are not well, they are suffering. So the starting point itself is negative, right? That is, nobody is looking forward to coming to a hospital. We go there because our bread and butter is there. We get salary from there. That's why we go there. Otherwise, as a patient, I'm sure, at least I don't want to go and lie there as a patient. I would assume that must be the same for uh, most of you. So nobody likes to get sick, nobody likes to suffer, nobody likes to be in pain. So the starting point in our profession, in our patient and family contact itself is negative. Plus, they may have had lot of other stressors. You know, there might be a shortage of water in their house, and that is a stress, electricity problem, traffic problem. By the time they reach the hospital security might have not been very kind to them. Then they may have to wait a lot of, a long time in the reception area. Nobody was kind to them, nobody asked them, whether they want a glass of water. In our healthcare, nobody asked these kind of questions, whether do you want, whether you're hungry, do you want to have something, if it is getting late, do you want a glass of water, do you want a cup of tea. Nobody asks these kind of kind questions. So just sit there and long time. Sometimes they see that people who came well after them, their arrival, they are going and seeing the doctor before. And so a lot of things, a lot of different stresses can add up into a person, and ultimately that person really gets angry. It's like a volcano erupting, and and you see somebody is spewing lava outside your OP or inside the hospital near the ICU or outside the casualty or the emergency department. You can see people getting very angry, shouting in loud voices. So then you are able to recognize that somebody is getting angry. So just to define what anger is, basically it's an emotion. It is not a pleasant emotion, it's a negative emotion, and it consumes a lot of energy. It takes up a lot of energy. It is not a low energy emotion. And then we have to figure out what are the sources of this energy, how we can cause anger, aggravate anger, and maintain anger. One source of energy is confrontation. So the various ways of confronting a person can be arguing with that person, or giving excuses for whatever happened. Or sometimes if the patient is very angry, even apologizing can increase the anger. So depending on the patient's or the sorry, not the patient, the person who is angry, any kind of confrontation can be a source of fuel. Another category of fuel is ignoring the angry person. You may be not making eye contact with the angry person because probably you are afraid. You don't feel confident. Or maybe you are feeling nonchalant. You say, that person is getting angry, let him be angry. I don't care. So you probably you are arrogant. I don't know. And that, if you are not, you have turned your back on that angry person, that also may be a fuel which will increase the patient's anger. So any kind of confrontation or any kind of ignoring the angry person may behave like a fuel which can sustain or aggravate the anger that is happening over here. So having understood that, we have to deal with it without confronting or without ignoring. That is the simple message that I wanted to convey by trying to convey what are the different sources, the two category of fuels that we just talked about. So here is an angry situation. This person is, using expletives, not very charitable towards your genes or your parents, and very loud voice. You can see the facial expression, very aggressive facial expression of this person, and we have an angry situation in our hands. And in this situation, if we don't manage, it can easily go on to become a law and order problem. So it's very important that we manage the anger situation in our clinic, prevent it from becoming a law and order problem. And how do we go about it? The same thing that we talked about yesterday. The major communication strategy is always non-verbal body language. So let us talk about what is the body language that we have to adopt when dealing with an angry person. First and foremost, stand up. Why? Because when somebody is angry, there is so much of adrenaline in that angry person's body, that person just cannot sit down and relax. That person will be standing up or walking around, pacing around, and showering abuses. So, body position has to be equal. Yesterday, we talked about body positioning. We talked about how you can increase satisfaction by sitting down. Here, you can increase satisfaction by standing up, because here you are positioning your body similar to the angry person. By this, you are showing equality. Many times you may have seen angry situations happening in WhatsApp videos and all. You will see that initially there is a lot of argument. The doctor is sitting in his or her chair, and countering the arguments by the group of people, and eventually the anger increases, and then people jump on the doctor. So many times when the doctor is sitting and other people are standing and arguing, the body language is conveying, I am superior to you, I don't have to equalize myself towards you. So from our point of view, we may not have thought of it, because most of the time it never occurs to us. So that is why it is important to be skilled in body language. So the moment you are seeing a person in your vicinity getting angry, stand up, because that shows equality. And then we talked about body posture, and we said a slight kyphosis increases satisfaction, because it is showing I am here to listen to you. So while you're standing, a slight kyphosis shows respect, not an exaggerated kyphosis, a slight bending forward. So the way this person is standing with the hands in front is a very, very good example of how we can stand respectfully. And the hand in front, the showing of the hand is important, because it shows I'm not a threat to you. And there is a lot of psychology that goes behind it, because from evolutionary point of view, showing the hand clearly shows that I do not carry a weapon. So it is ingrained in our psyche. So we are saying I am not here to harm you, I am not a threat to you. So this is the three important things: stand up, slight with a slight kyphosis with the hands where clearly the angry person can see. Now let's focus on your face. Eye contact. Don't shy away from making eye contact, because eye contact shows I am not scared of you, I am confident. So as a doctor, as the person over there, you make eye contact with the angry person. But here, do not smile, have a serious face, because when you have a serious face, you are showing that I am taking you seriously. And then nod your head, because the nodding of head is about encouraging the person to ventilate. So nod your head, because then you are allowing, because like last time I had said that to encourage a person, to patient to talk, not only you have to make eye contact, you have to also nod your head and make encouraging sounds like mm-hmm, uh-huh, okay, go on. But here don't make sounds, just silently nod your head while you're making eye contact, and don't smile. So these two things about your body language, your body and your face, these two things are neither confrontational nor are you ignoring the person. In fact, you are encouraging the person to ventilate. Please remember, it is just an emotion. And if you allow it to ventilate without adding fuel to the fire, it will quickly go down. Because now, when you are doing this, the patient is still angry, but the severe anger comes down. And how do you see that? The bad words comes down, the expletives comes down, and then the volume of the voice starts coming down. The sharp tone of the voice comes down. The facial expressions becomes less aggressive. So this is what happens, and this happens very quickly because it's a high energy consuming negative emotion. So if you do not give fuel, it quickly drains down, but it does not die down completely. It just drains down from a high flame. It comes down to a simmering flame. And once you have a person in simmering anger, not in very high anger, then you can open your mouth and then invite the person to sit somewhere and talk about this. So you're not saying, you're not giving any justification. You're just saying, I want to know more about this. Can we sit down somewhere and talk? And at this point of time, when the anger from high flame to it has been brought down to simmering anger, then at this point of time, you give an invitation, and then you continue the person to allow, you continue to allow this person to ventilate whatever distress the person has. So you continue the same body language, but now you're sitting. You are now sitting with the patient, and a slight kyphosis. Keep your hand on the table where the patient can see the hand. Make eye contact. Keep the face serious and keep nodding your head like that. And then you will see the simmering anger will also starts coming down. And many a times in my personal experience, I have had plenty of experience of dealing with angry people. And many a times what happens is, one uh, as the anger comes down, eventually sometimes they break down and cry. And sometimes they apologize without anything. They just, in the end, they just apologize. I'm sorry, I said so many things. So this is how usually we'll deal with it. And how to end it: you have probably, when you have allowed this person to talk, ventilate, you may have picked up some of the reasons why this happened to begin with. And if you have a solution, do give a solution. And if there is a merit, a real merit for an apology, only then give an apology. Otherwise, don't apologize. It is not necessary to give an apology. Definitely don't give an insincere apology. An example being, thank you for bringing this to our notice. We are very sorry you had to experience this. And another example is, thank you for bringing this to our notice. This is what we are going to do so that something like this doesn't happen again. So previous one is with an apology. The other example is without an apology. So we thank them for, you give them this feeling that, all said and done, we are grateful that you brought this to our notice, right? So this is one way, good way of ending it. So last slide. When it comes to managing collusion, the key point is listen to the family. When it comes to truth telling, remember, it cannot be your agenda to tell the truth. You are only a facilitator of information. The patient decides whether they want to know, and if they want to know, how much they want to know. Ventilation of emotion, whether in the form of tears or in the form of anger, is not a waste of time. It's a very, very important psychological tool that you have. The analog is ascitic tapping or pleural tapping. It really relieves the person after the distress has been tapped. And anger management, among the three skills we talked about today, the three procedures we talked about, the most difficult is collusion management. The intermediate difficulty is of truth telling, that is communicating bad news. And comparatively, the easier skill to practice, master and practice is how to manage anger. It is just a non-confrontational ventilation of emotion. And that is what anger management is all about. And with this, I will come to the end of my presentation. And uh, if there are questions, I'll be happy to take. I'll stop here. There you go. We are done.
Thank you. Thank you so much, sir. There are already a few discussions happening in the chat. Uh, So one person have told that it's very new, that to ask whether they want to know. And there is one comment on second or third opinion. Most of the time, I find that the patient don't disclose that they already know. They just want to reconfirm for a second or third doctor. That's one comment. And one question: what happens when breaking bad news becomes a conflict of interest and backbiting between doctors?
Between?
Doctors.
Okay. As if we didn't have enough problems dealing with our patient and families. Yeah. So collusion can happen within the family. The patient knows is colluding with the family. The family knows is colluding with the patient. Sorry, the truth may be known to the patient as well as the family, but both may be colluding with the doctors. The patient says, "Don't tell my family." The family says, "Don't tell the patient." So both parties know, but they don't want to acknowledge it between each other. So between in the house, they all pretend as if nothing is going on, right? So that is one thing. Another complication is that the patient wants to know, the family stands behind and says, "Don't tell, don't tell." So then what do we do? So many times we have to buy time with the family. We have to buy time with the patient, and meanwhile we'll try to, manage collusion with the family. Difficult situation. We are in a spot, but uh, when I tell the patient I don't have all the information, I will get back to you when I have all the information. And am I telling the truth? Am I lying to the patient? Let me put it this way. I may know 100% the medical information that I have, but what I don't know, and this is the truth, what I don't know is whether the family will agree about sharing the truth with the patient. That I really don't know. It is something that will evolve over a period of time. So when I tell the patient I don't have all the information, that means medical information maybe I have, but the other information I don't have. And I will come back to the patient once I have all the information. So in that sense, I am not really cheating the patient. I really cannot get on to the truth telling with the patient without the family backing me. And till that happens, I will try to do everything possible for the patient except having that honest conversation. It is like fighting with one hand tied behind your back. It is not the best situation, but then we try to make the best of whatever situation we find ourselves in. And the other thing about doctors having conflict, we talked about it yesterday, and I think the only way to go about is making an effort to have interaction with our colleagues. Just pick up a phone, that this is what I have talked to the patient or the family, and that kind of probably should help. Personal uh, policy: never badmouth a colleague. Never badmouth a colleague, whether the person is working with you in your department, in your hospital, in your city, or anywhere in the world. Never badmouth a colleague. And if possible, say something nice about that person.
So I think Sanjaya, please go ahead. You raised the hand first.
No, ma'am. Actually, I had a very difficult case today. I'm still very confused and very worried. And I don't know how to approach this patient. Patient is 15 years old. She has come with functional blindness. Her parents have given permission, and her sister is accompanying the patient. And we have to break bad news to her. And at the same time, this patient has gone through a life event, and this the patient is having post-traumatic stress kind of a reaction. Her reaction is when she has to face anything that the doctors are telling, she tends to go back to sleep. So they were trying an old technique called ab reaction, in which we give thiopentone and put the patient to sleep, and they give a kind of a hypnosis suggestion to try and get a block, her mental block and her emotions out. So we've got this kind of a patient with other things that I cannot disclose. So since it was to do with communication skill, I wanted to know, sir, since the patient cannot see, otherwise she's talking and she was telling us that she's willing to talk. But, you cannot exactly address the elephant in the room. We had to just beat around the bush. How is your normal day? What do you enjoy doing in the ward? And now the child has learned to go to the washroom by herself. She sits and draws and gets colors from her sister who helps her out. But we are not able to assess or to tell her what disease she has and how to help her. She just takes her medicine on time. So we're at that phase of dealing with her. So I just wanted to know how could we improve. Today I got few points from you, sir. But since the patient is functionally blind as of now, in such difficult cases, what can be done? Because even psychiatric people were very worried. And we were also discussing as to how to break, because the mother doesn't want to talk about it to the child anymore. And in such situations, what do we do? Buy more time, sir, or let?
I guess this is a very, very specific thing. Feel free to contact me at some later
Yeah, so
point of time,
I made a note
because
of your number.
we
Yeah.
may have to have a 1 hour discussion on this. We just don't have the time for that.
Yes, sir.
And so feel free to contact me. Like
Thank
there
you,
are
sir.
colleagues who from various
Mm.
places who do. I don't have the answer for it. It's just a thing about we discussing and seeing
Uh-huh.
what are the possible ways we can go about it. So feel free to do that.
Huh.
So and probably
Because
we
she's
can
15
discuss.
years, she's
Yeah.
in ninth standard. So she understands she is in hospital. She understands that the tests are being done. But she is blind currently, and it is functional blindness. They are not finding a cause for that. And her disease process or whatever, that's a separate issue.
Yeah.
So we're just at this point right now.
Broadly, we need to
Yeah.
figure out what does she understands about what is happening to her, and
Mhm.
then take it from there. So that part, you can discuss whether she's blind or not. We don't know the answer to her blindness and or not. That is immaterial. So maybe the starting point would be that. Specifics we can talk
Yes,
outside the
sure,
group
sure. Thank
at a
you, sir.
at a
Thank you, sir.
later
That's
point
why
of
I
time.
lowered my hand. Thank you, sir. Yeah,
Thank you, sir.
Yeah.
yeah.
Dr.
Thank you,
Anish.
sir. Thank you, ma'am.
Yeah, good evening, sir. It's
Hi,
a
Anish.
very
Yeah.
nice talk, sir. I just had a few doubts, sir, because since I work in an ICU, there are a lot of times when we have to disclose the bad news as in the death of the patient. So, what we do right now is even if the patient goes for a flat line, we'll just wait for some time, get an ECG done. Like initially, we will tell that the patient is critical and bad in a ventilator and all. We'll wait for some time, like step by step. Usually, we'll take 3 steps to disclose the bad news that the patient has died. Such a point only we are doing. But even sometimes we get angry situations, even if we go slow. Is there any alternate way for that? That is one thing. And second thing is that always, when these sick patients come to hospital, there are immediate relatives, or they obviously understand how the doctor is trying his best to save the patients. But there are some distant relatives, like the fathers, sisters, uncles, some nearby politicians will be there, who are there just to make an issue. So these kind of people usually don't let us explain properly to the relatives, or even breaking the bad news in front of them will be more problematic. They tend to create a problem there. So is it like right now what we do is we will keep them outside. We don't talk to them. So they create a problem outside. Is there any other way to like convince the distant relatives also to be the part of the conversation, even if they come to make a problem there?
Thank you, Anish. Two excellent questions. ICU communication skills is definitely a subject in itself. I mean, we just don't have time for it. So I'll just briefly, I will mention that again, as I said, communication is always a team sport. It cannot be just one person's cross to bear. The team sport in this particular case really involves very good coordination between emergency medicine department and critical care ICU intensivist department. These two departments really have to start talking more to each other, have a work as a team, because a lot of patients who are shifted to ICU are shifted from the emergency department. Of course, happens from the wards too, but by and large, this happens. So the communication should start from the point the patient and family set foot into the hospital. Again, truth telling appropriately. And we understand that it's a dynamic situation. We ourselves don't know what is going to happen, what are the outcomes, we don't know. And telling that truthfully is the important part. We really don't know how things are going to develop. We hope things will turn out good, but also be prepared for things turning out very, very bad. And when we say bad, also be very specific in using words. For example, when I used to work with Pallium India, I had an experience that a patient was brought in from another institution saying that this patient is serious. And when we saw the patient was gasping. So we knew this patient was going to die. And then we told the family members, see, this person is going to die. And when we used the word in Malayalam, we said that ഇപ്പോൾ കണ്ടീഷൻ മോശമാണ്, മരിച്ചു പോകാൻ സാധ്യതയുണ്ട്, അങ്ങനെ മരിച്ചുകൊണ്ടിരിക്കുകയാണെന്നാണ് നമുക്ക് തോന്നുന്നത്. Basically, what I said in Malayalam was things are very bad. There's a good possibility that he may die. In fact, we believe that he is right now in the process of dying. So that was the first time the family members realized, oh, this person is dying. Because all this time they were just saying serious, honest, that the person is serious, serious, serious. But it never occurred to them that serious means this person is potentially going to die. So we as doctors sometimes shy away from using words because we feel that we may appear very harsh. We shy away from using the word cancer. We ask, is that disease? Or words like that. So we try to point them to a certain this thing without being specific. So we have to get over our inhibition of using words like cancer, uh, potentially going to die, or maybe there's a good chance of dying. The word death, dying, etc. should come. And of course, you have to use it sensitively. The word itself is not the issue, how you say it. If you say it callously, it will scald them. If you say it with sensitivity, it is still a bitter pill, but it still goes in. So it is not what you say, how you say, but clarity has to be there. There is no question of beating around the bush, especially when you have very limited time. Another thing very important in critical care or emergency medicine communication is you have to keep a running commentary going on. So if you are the intensivist in your hospital, you can't be expected to come out and brief the family every half an hour about what is happening. Things are, the BP is falling, and after another half an hour, we gave this medicine, the BP seems to be picking up. Another half an hour, the BP is still going down, the breathing is going down, we are going to put in a tube. So, you can't be expected to do, briefing of the family every half an hour, but somebody has to do. So develop a team. In your team, there might be other doctors, there will be nurses, there'll be social workers, and let the whole team know what is going on. And then, by rota, somebody goes and talks to the family. Good news, bad news, whatever news, the family gets to hear about it, know about it in real time, so that there are no surprises. So when the patient is taken into the ICU or taken into the emergency room, the family is waiting outside, not knowing what is going on, and then finally things, after a long time, they are given a bad news, then they blow up. So the crux of the matter is keep them updated as frequently as possible, and hence, this being a team sport, you cannot have one person being burdened to convey the information, right? So that is in a nutshell. Of course, it is an inadequate way of explaining it, but that's in a nutshell. The second part, I'm sorry, this is taking long. The second part is, what do you do about people who come in later, the sister from California syndrome kind of a thing. People coming in later and demanding that, I want to know what is going on and why are you doing this? Why are you not doing that? Etc. Etc. I think the solution to that, at least that's how I practice. The solution to that is, when I have something serious to convey, when I have something substantial to convey, I tell the family members, call everybody who is who of your family, who has any stake in this patient, call them, and uh, tomorrow 4 p.m. I'll be available, call them. Or I ask them, what day is convenient for you? Is it convenient today? Is it convenient tomorrow? What day? I want to talk to everybody. The reason being, when I talk to everybody who matters, then all of them are hearing what I have to say at the same time. I put them, they're on the same page. And thereafter, if anybody has any question to ask, everybody hears the question at the same time, and they hear my answer at the same time. So when I'm done telling the truth, and if they have any questions, there might be some family members who know more. There are some family members who know less. And if the question has come from a family member who know less, the answer may not be given by me. The answer may be given by a family member who knows more about the situation. I just have to sit and watch the discussion happening. And somewhere I may sometimes steer the discussion into a place where we need to go. Now, the advantage of that is everybody is up to date, everybody's on the same page. We may be uncomfortable dealing with it because all through our learning part and practicing part, usually one or two bystanders are allowed into our room. I say, bring everybody, bring even the neighbors if you want, if they are also part and parcel of the decision making process. So in my room, I have a way of arranging things that easily 10 to 15 people can sit. And I am not afraid of the large number because I am in total command of my environment, right? And this saves me time, energy, effort. And pre-COVID, this was the normal. After COVID, now gradually we are opening up, but during the peak of COVID, we were using in Rajagiri where I work, I'm having the advantage of having telemedicine, and we can connect to people across the world and have real-time conversation about this. Or even if that is not there, with WhatsApp or Zoom, we were connecting with family members. One person is in Bangalore, one person is in Riyadh, another person is in US, and we are having a discussion on serious healthcare issues and how to go about it. All of those things, whether to send to opt for critical care or end of life care, all this kind of very complex discussions we were doing online, which we were doing offline earlier. So once we got comfortable with online, I realized it doesn't matter whether we are, right now we are having a conversation with, all of us together, and we are fairly comfortable doing that, right? So the answer to that is, get everybody together, then have the conversation. Advantage for you is you save time, energy, effort while you're conveying. And then you will not have one elderly relative who feels offended, I have not been included in this, and then that person puts a spanner into every decision that is taken and confuses the family, confuses us. So those kind of problems also we can take care of it once we get everybody together for a discussion.
Thank you, sir. We have a case presentation today. I have to rush for that. I'm so sorry. Dr. Sujay, without much time delay, we'll start.
Okay, madam. Good evening. Good evening to all. A 28-year-old female diagnosed with infiltrating ductal carcinoma left breast grade 2. Next slide. Came with presenting complaints of recurrent pricking pain and swelling under lower part of the breast since 3 months. Weight loss and generalized tiredness since 1 month. History of illness: she had recurrent pricking pain lasting for 4 to 5 minutes, and swelling size was about 4 centimeter, hard in consistency. Under the lower part of the breast, dimpling of skin noted. I'm telling only the positive things. And history of weight loss of about 5 kg within a month, and no with generalized tiredness since 5 months. So no history of fever, diarrhea, spine or body pain. No immunity noted. No loss of appetite. Bowel and bladder habits are normal. No history of diabetes or hypertension. Going to the examination, all the vitals were normal. She weighed 51 kg with height of 161 centimeter. The positive examination findings: left axillary lymphadenopathy was noted. On examination of the left breast, a lump noted over the left quadrant of the left breast, dimpling of skin over the swelling noted, and other breast appears normal. On palpation, the size was 4 to 2 centimeter, hard in consistency, mobile, not painful. The fixed palpable lymph nodes present in the left axilla, and other systems were normal. Treatment and significant investigations: currently on Tamthro 20 milligram. She has received chemotherapy, radiotherapy, 26 cycles of chemotherapy and 25 radiations. Investigations: plain FNAC showed a lump with showed a carcinoma of breast. True cut biopsy, mammogram, and PET scan, everything was suggestive of infiltrating ductal carcinoma. Psychosocial aspects: she's an unmarried, worked as a high school teacher and discontinued due to illness. She is living with her elderly mother 80 years in a rented house. Now she has to depend on others for financial support and medications. Her father got separated from family at her childhood. She has protein allergy detected recently, but it is not related to the disease. She feels lonely and insecure. She often gets frustrated, depressed. She stopped going to church. Next slide. Medications. Presently, she is on tamoxifen 20 mg for 5 years, and multivitamins and prednisolone for allergies. Next slide. The main concern is psychosocial support, that is support for the mother and herself, fear of thought about the survival, that whether the disease will recur, feels guilty that she has to depend on others for getting medication and financial support, has feeling of whom will marry after knowing such life-threatening illness. She is undergoing several ups and downs in spiritual life. She is living in a rented house, left job due to illness and medication. Next slide. Summary: 28-year-old unmarried woman lives with her elderly mother with infiltrating ductal carcinoma of the left breast on medication. She is improving. Before going to the discussion point regarding this case scenario, how she has this communication, how we have communicated about the bad news to her. So, making precise, a 28-year-old unmarried woman working as a high school teacher, she had a doctor friend. When she had pain and lump in the breast with loss of weight, she asked her opinion, what to do. And she is a lady orthopedician. She suggested to do an FNAC. When she she has done an FNAC, and when she went to buy the report, FNAC report from the lab, we don't know whether the pathologist or lab technician has said to her not to open the report. Give it to the concerned doctor who has asked you to do FNAC. But before leaving the public health lab, she overheard saying between them, saying in a colloquial, in a Malayalam language, that's she overheard. That is, her life is in danger. With great fear, she took the report to her doctor friend. She, after seeing the report, her doctor friend expressed as the word "ayyo." The report given shows bad results and advised her to go immediately to RCC. She went there. Doctor from oncology department, after seeing the report, held her hands and gave her the news. It was cancer. She heard that and she screamed and ran out of the campus. She was consoled, saying we have to confirm the diagnosis with few more investigations. And she was left to the counseling, saying that you please go and attend a retreat and come a week with the following investigations. After a week, she has planned to, she has decided, she has come in a mindset to take treatment for cancer. She was ready to take what all the treatments they have planned, like chemotherapy, radiation. In the meantime, before posting for a surgery, the same surgeon explained her that mastectomy might need to be done. We don't know if there actually in ultrasound abdomen there is no any other metastasis. Mastectomy might need to be done. That only will be decided on table. When she heard this term, she said, "I will commit suicide." Then again, the doctor has to console, saying, "I wish your life to be very safe, more than losing or removing the affected part. I will try to preserve your body part, but I wish the disease has not spread." But later, only lump and left axillary lymph nodes are removed, and latissimus dorsi flap reconstruction was done. Now she is on only tamoxifen for 5 years. And now coming to the discussion points. Who should deliver the news? Either the treating doctor or her friend doctor or nurse or lab technician. Next comes the question, how to deliver the news? And what to say and how to say. I think almost everything has been covered. Where to deliver the news? Who should be present at the meeting? Patient alone or with the parents, if it is a pediatric? Will it be helpful to include a nurse or social worker? How to acknowledge emotions? How to follow up after delivering the news? Thank you.
Thank you, Dr. Sujay, for the elaborate presentation. You have touched upon all the conversations that has happened between the patient and the doctors. Thank you so much for bringing that in. Yeah, as you said, most of the aspects are covered. Maybe, but in, Dr. Biju, maybe many times patients hear their diagnosis something like this, hear from someone else, and then do you think it is more challenging when we have to break the bad news again, because they might have heard in a very traumatic way in the past? So how to deal with that?
Well, unfortunately, despite best intentions from the side of the doctors, I mean, of course, no doctor wants to cause suffering to the patient, but the tragedies, as I mentioned yesterday, all that we are taught is diagnostics and therapeutics. Nobody teaches us in medical colleges how to talk, communication skills, ethical decision making. These are things which are not taught to us. So, and since we are so inadequately prepared, we make a mess of it, and unfortunately, our patients and families bear the brunt of our poor skills or poor knowledge on this. Not our fault, it is the fault of the system never it's unfortunate that in many of the developing countries, a lot of emphasis, a lot of time, energy and effort is made to teach medical students communication skills, and a lot of these skills start they start teaching them even prior to clinics. And in our country, this 8com has just come about. It looks good on paper, but frankly, how it is being implemented needs much to be decided, but we can always hope for better days ahead. Presently, I guess when you have a patient who is already traumatized and coming to us, we just have to use our skills and empathy in healing the patient's emotional wounds, apart from also dealing with their other suffering. Sometimes, more than the disease, a lot of suffering is piled on the patient by, not intentionally, but by the family as well as the medical professionals. So I guess, people like us, we are doing this all the time. Uh, so and we are doing it not because we just fell out from heaven with this kind of skill. It is something that somebody taught to us, then somebody mentored us, and then we practiced it ourselves and we got better. Now we are teaching others. That's about it. Just like any skill in medical practice, somebody teaches us, then we practice it, we become good at it, then we teach others. And hopefully classes like this will happen more often, and more doctors will come forward to get trained in communication skills. So I mean, all of you who are right now, uh, can we have this slide off? Maybe we can
Yes,
hopefully
yes.
see others. Yeah, this is better. So hopefully what happens is each one of you uh, uh, take up a leadership position in your institution and insist on communication skills be taught to everybody in your institution. That's something that I talked about. Uh, in Rajagiri, last year we did a module for all the medical officers, the junior doctors and PG DNB students. And I did that 5 modules, and 3 were on communication. One was basic that we had yesterday. The second was on the procedures that we did today, and third was communicating on end of life care with patient and family, and the fourth one was on pain, and the fifth one was on medical ethics. So the 5 module, 1 hour each, we did at Rajagiri. uh, the point is, sometimes it is very difficult to get the senior faculty to come, and there can be many barriers. They don't have time, maybe they don't understand why it is important. And another thing is that, hey, I've been doing this for 30 years, why should I need to learn this? What is there to learn? And also this kind of thing. And sadly, they may be the best people who can make a difference, because they are really high in the hierarchy, and people will listen to them. So so that's it's a difficult task. Been doing this since 15 years, trying to teach. So wherever I get a captive audience like this, I try to try to influence and inculcate as much as possible, and urge uh, anybody who would listen to see that communication skills is part and parcel of our skill set. And if it is not there, we can, do something about it. So hopefully, gradually over a period of time, the traumatic experience of our patients, the words with which we cut their soul, those incidences will come down, hopefully. I have a feeling I did not touch here or there. It was kind of vague, but then that was the best I could do for the time being.
No, sir, because most of the questions in the presentation was covered during the session, like who, how, and when, where. So everything was covered during the session. Only thing was that that I mentioned, like, already got the bad news in a very wrong way, so they may want to how to deal that you covered really well now.
No, but thanks, Dr. Sujay, for bringing up this presentation, because it kind of reinforced the problems and the difficulties, and we had the answer and then the question. I mean, it would have been better if we had the case presentation in the beginning and then the session later, but doesn't matter. It's anyway a tilted world. So, I mean, the point has been reinforced that this is the difficulties that we face, and and let us go back to the sessions and see how we could have tackled.
Thank you, sir. Thank you. Thank you very much.
Thank you so much, sir, and thank you so much, everyone, for the interactions. If you have any more questions, please feel free to write to us. We can forward it to Dr. Biju, and he's given the email in the PowerPoint, so you can always contact him through that. So thank you so much, everyone, for yes, sir, please.
I'm very bad at checking emails, so feel free to share my number. Many of my friends, like you, they contact me over WhatsApp and things like that. If they have any, some issues that they would like to discuss, like just before Dr. Sanchia had mentioned. So probably, we'll catch up with each other sometime later, something like that. Feel free. I'm only happy to do whatever I can to help out our colleagues in a way. I mean, so feel free to contact. Yeah.
Thank you, sir. And the
Thank
chat
you very much,
box.
sir.
And the chat box is full of compliments as usual. So that's not
Com-
something new to you, but yeah.
no, compliments are great. It lifts your spirit. And I
Yes.
always tell people, never let a day go by without you complimenting at least one person. Say something nice about at least one person. If you can compliment 10 people, great. So this habit of giving compliments is very important. It creates a lot of positive energy. Your compliments has really given me a lot of positive energy. I don't feel tired at all after a full days of work, and then this 1.5 hours or close to 2 hours of interaction. I am boosted up with energy, and that is thanks to the compliments that you are given. So I urge everybody to practice giving compliments. Compliment at least one person every day.
Thank you, Dr. Biju Raghavan, sir. Thank you so much. So, with that warm and positive note, this is Sri Priya, along with Dr. Biju Raghavan and Dr. Sridevi Warrior, signing off from the Tips Eco Hub. See you in the next session. Till then, everyone stay safe, be happy. Bye bye.